Good evening, colleagues. I hope you can all hear me. Welcome to another Clinix Health Group webinar on a Thursday evening. I hope that those of you that are in Johannesburg, as I am, have something warm to drink. You've got your blankets around your feet. And those in Durban, other places, I hope you are also really comfortable. Welcome to our presentation this evening. Dr. Kinoshi will be joining us here in the background, and I'm sure you'll participate a little bit later in the evening. Our topic this evening, vaccination in pregnancy and the current practice by Dr. Amy Wise, will be really insightful. And Dr. Wise will also be able to give us a little bit of background about Rahima Musa Mother and Child Hospital, where I was born in 1977, and she was born a little bit up the road from there. But before we continue, I know that you'll find that most of you or all of us are muted. And so if you could please stay that way so that we do not disrupt Dr. Wise during the course of the presentation. And we will, as the evening progresses, feel free to submit your questions and we'll attempt to answer as many of those questions as we can during the course of the question and answer session. The presentation, as you know, will be CPD accredited. So for those of you who registered, will be able to receive their CPD points automatically from the HPCSA. And again, Dr. Kinoshi emphasizes it every evening. Sometimes once you've registered, you will receive a link. And so the link is often sent to colleagues and the colleagues click on the link, but they do not receive the CPD points. So the reason why you register is so that we can receive your registration, your MP number, for instance, and that you can be credited with the CPD points for the presentation as well as the topic that is covered. So Dr. Wise is here with us this evening. I see there are quite a number of colleagues that are still coming online. It's around about 206 colleagues. I told Dr. Wise that she shouldn't be overwhelmed, but she was quite comfortable to continue with us this evening. A little bit more about the speaker. Dr. Wise is currently the head of the clinical department of obstetrics and gynecology in Rahima Musa Mother and Child Hospital in Johannesburg. She joined the hospital there in 2009, and she's currently a subspecialist in maternal and fetal medicine and a senior lecturer at WITS. So Dr. Wise's vision is to engender respect for women's healthcare in the undergraduate students and to ensure postgraduate students and colleagues they continue to develop their passion for obstetrics and gynecology by creating a collaborative learning environment. Dr. Wise was elected to the Council of South Africa Society of Obstetrics and Gynecology in 2021 as well as 2024, and as the South African Gauteng representative. So in 2023, she was appointed to the College of Obstetrics and Gynecology, and she chairs the maternal and fetal subcommittee there. She's also involved in several research units, including Empilweni Services and WITS Vida and Ganyezi Research Unit, both based in RMMCH. As part of her interest in research and academics, she chairs the WITS Obs and Gynae Protocol Committee and is part of the WITS Human Research Ethics Committee. Research interests include high-risk pregnancy care, vaccination in pregnancy that we'll be discussing today, climate change, interestingly, and the impacts of these different components on maternal fetal diet. She has authored and co-authored numerous peer-reviewed articles and papers nationally as well as internationally, and has done numerous conference presentations. Dr. Wise is very well spoken, and she is somebody that wants to impart her knowledge to her colleagues, and she gave us assurance that she will really attempt to answer as many of the questions as possible during, as I said, during the Q&A session. I'm going to welcome you, Dr. Wise. I thank you so much for joining us this evening and taking the time to prepare your presentation. And We know that it's going to be a really insightful and education-filled evening. And so we look forward to hearing your presentation. Thank you, Dr. Wise.
Thanks so much. Thanks so much, Dr. Shinners. It really is a pleasure to be with you tonight, and really thanks to the Clinix group for the invitation to speak. We said when we were chatting just now that it's a little bit of a cult. We do believe in what we're talking about, the people who are interested in vaccination and pregnancy, just because of the huge health benefits and everything that we can get from it. So if it's all right with everyone, I'm just going to is it all right if I turn off my video? Just to kind of save myself a little bit of bandwidth here, so that I don't suddenly disappear. Okay, great. So I was asked also to just say a little bit about Rahima Musa Mother and Child Hospital. So you heard that I've been there since 2009, so I'm a little bit part of the furniture. And I did my undergrad at Wits and then rotated there at some point as a student. And I then have started out as a senior medical officer there, went on to being a consultant and everything. So I do love that hospital, and I truly do love the community that we work with. So currently we're draining the patients all the way from the west to sort of Krugersdorp way. Yusuf Dardu and Leratong refer to us, and then all the way out to Diepsloot, which is about an hour's drive from Rahima. But if you're taking an ambulance, it sometimes, we take 2, 3, 4 hours even to receive our patients. It really is quite tricky. And then we work as a complex with Helen Joseph Hospital down the road, which was the old JG Stradorm. And although it's a kilometre down the road, sometimes it feels like it's loads of kilometres down, sort of 10 kilometres down, because it takes so long again for us to sometimes work with them. And then anything particularly complicated, cardiac patients and stuff, we will refer to Joburg Gen, to Simja. So we're delivering just over 12,000 babies at the moment a year. This is down from a high of about 16,000, which was in 2019. So there's been a slow reduction in the number of deliveries, but it's still not as low as when I was a registrar, where we were delivering around 8,000 a year. So it really is a massive burden of care. We've got a Caesar rate at about 45%, and that's up from about 37% a number of years ago. So there's that slow increase in Caesars, which obviously then impacts the sort of high risk nature of it. I mean, just this week alone, I've sent 3 major placenta previas with invasion placenta accreta spectrum patients to Simja. Because we don't have surgeons on site, we don't keep those patients with us, and we don't have a 24-hour lab or blood service. We have to get our things from down the road. So we rely on a blood fridge for, at night if we have a problem, and otherwise we have to bring in the stuff from down the road. Our gynae service, our gynae regs are seeing between 40 and 60 patients a call. With anywhere between sort of 5 and 15 admissions. So it is a very, very busy place. Our antenatal clinics, when I run my clinic on a Monday, anywhere between about 140 and 200 patients, between 8 or 9 doctors. So we do have our work cut out for us, but it is a great place, and we really do try very hard to make sure that our patients receive the best care possible. So yeah, I've got a great team who works with me, and I'm very grateful to them. So I hope I'm going to start. We're going to be chatting about vaccination and pregnancy. So just as a disclosure, I have done some work with both Sanofi and Pfizer over the last couple of years, and I'm very grateful to them. So, okay, let's see that this now works. And of course, it now wants to misbehave. There we go. Right. So this is from the new Department of Health, the National Department of Health 2024 guidelines. And in this, you can see how they're sort of laying out their priorities. And one of the things that we're looking at and how to reduce the morbidity and mortality, in the top left-hand side there, we've got the perinatal deaths. And one of the things that we're targeting is maternal vaccination. So what they've included there is tetanus toxoid, hepatitis B, and flu vaccine. So those are the things that they mentioned. And this guideline took quite a while to come out. The first guideline was in about 2017. And obviously there were a lot of iterations to put out another one, and it really was about time. But as with all things, these things always lag a little bit behind, so it does not yet include RSV. So this was the previous guideline recommendation from 2017. So if you have a look at it, they're talking about pregnant women receiving tetanus toxoid or TD, and we wanted patients to get it as soon as possible once they were pregnant, and then 4 weeks later, and then preferably 6 months after that. So in reality, most patients wouldn't get that third dose, depending on when they booked at the clinic. But tetanus really is something that needs to be kept in mind. As much as you don't often hear about it, when it does occur, it is devastating. So this was all that was in that 2017 guideline. So the new guideline has got then Tdap, influenza, and COVID-19, and then if indicated, and this would have to obviously have to be someone who's at very high risk, the polio, IPV, hepatitis B, rabies, but not included really just because it hadn't quite been registered here, was RSV. It was in the process of being registered, and it was all very new, so that wasn't in yet. So why do we worry about the vaccines, and what is the point of it? So the vaccine preventable morbidity and mortality, so far the programs like the EPI, which was started in 1974, the expanded program, has targeted children, and they really have benefited the most with a decrease in disability and death. So the thing is that if you now look at where is our morbidity and mortality coming, data out of the US showed that 42,000 adults versus 300 children die every year from vaccine preventable illness. So there's been a shift in the thinking more towards a life course approach to vaccination, that it's not something that ends at sort of age 6 or age 12, that it is something that we should be looking at across a patient's lifetime. And I obviously have an interest in obstetrics, so the point that I'm looking at really then is that maternal vaccination. So more than 50% then of cases of significant vaccine preventable illnesses in the CDC in 2004, so it is 20 years ago, but importantly were in those aged more than 15 years. An article published last year in 2024 in The Lancet showed that vaccination has averted 154 million deaths, of which 146 million are within children, and then you can see the bulk of those in those under a year. So it has produced a 40% decline in global infant mortality. So absolutely vaccines are important, and we need to be focusing on them. So this is from that article in 2024. You can see the deaths averted due to vaccination, 154 million, and it's a cumulative graph going there from the left to the right from 1974 through to 2024. But the biggest savior really has been, or saving has been within measles. And unfortunately, I just heard just the other day that there was a death from measles, and this is something we shouldn't really be hearing about at all. We do see a drop-off after those initial doses of childhood vaccination, and this is something in practices who are seeing children and everything, opportunistic counseling and speaking to people about making sure that their children are fully vaccinated is very, very important. Patients often see it as being not their problem, their kid looks well, but it is until it isn't really. So pertussis, tetanus, Haemophilus influenza B, and polio were the focus of this particular paper. So maternal vaccination then has a look to try and find that period of vulnerability with infants, so that if we can vaccinate mom, can we protect babies in that first little bit from birth until they're able to receive their first doses of vaccination, so around 6 to 8 weeks. I've highlighted there, you can see my two blue arrows. One is the Tdap, or DTaP, as they put it in this graph, or influenza virus. And you can see that window of vulnerability in the first couple of months. And so what we want to do is leverage on that transplacental transfer of antibodies, as well as the breastfeeding of mums, to try and protect their babies in those first few months before they get actively vaccinated themselves. So we have then both that active and passive vaccination. So active immunization we give the vaccine to mom, and she produces the IgA, IgM, and IgG. So obviously the M not crossing the placenta, but the G does, and the IgA is secreted in breast milk. So then we have that passive immunization of baby receiving IgG during the pregnancy, and then baby later through breast milk will get the IgA, IgM, and IgG antibodies. So there are the two streams, the direct with the placental transfer directly sending antibodies across, and the maternal vaccination. And indirect, this is where we look at the fact that we are treating our whole population and we're attempting to get a herd immunity of at least more than 80% of patients people who are vaccinated. And so we also then do the boosters, school entry, adolescent and adult boosters. The other indirect method is a cocooning strategy. So this is where a baby is born and we then vaccinate everyone who comes in contact with the baby. So parents should be vaccinated and anyone else who's going to be looking after it or in the house. But that is quite a labor-intensive thing. If you're considering that my antenatal's got 150 women in it, to then try and bring in everyone from home to also be vaccinated, it is just not very practical. So the best option really is to vaccinate mom, and so that we can directly affect baby. So the optimal timing for immunization. So the half-life of maternally derived antibodies is quite short, and we want to try and extend that seroprotection as long as possible. So then you have this sort of toss-up between, do we vaccinate a bit later in the pregnancy or do we vaccinate earlier? So what has been found is that there's prolonged maternal-fetal transfer actually results in a higher amount of transferred IgG compared to a shorter exposure at the time of peak transfer efficacy. Obviously, your placenta gets better at it as time goes on, but if you vaccinate earlier, then we actually allow more IgG to transfer across. And it is with the principle of active transfer. So what we find is if we term infants, if they're vaccinated before 31 weeks, will have the highest level. And both term and preterm infants, if there was a 7.5 week gap or so between the vaccination and delivery, they have got the highest cord blood antibody levels. So vaccinating earlier provides equally high antibody levels at birth generally. And so we want them vaccinated in the second and early third trimester to try and provide equal benefits to both term and preterm infants. Our rate of prematurity in the country sits at around 15-ish%, 12%, depending on your population and where you are delivering. Are you looking at a high-risk population delivering somewhere like Rahima, or are you looking at a clinic level? But really, we don't always know who's going to be that preterm infant. So delaying vaccination, unfortunately, results in those who are most vulnerable not being protected. The other special population we look at are women living with HIV. So there is a trend for higher incidence of hospitalization for influenza, lower respiratory tract infection patients in those women living with infants who are HIV exposed infants, as opposed to those who are unexposed infants. Pregnant women with HIV, they have a lower seroconversion rate and lower persistence of influenza antibody, which is antibody specific, and a double dose is associated with a slightly greater immunogenicity compared with a single dose. So that was work done specifically on influenza, but it is similar and is thought to be similar with the other vaccines, that they might have a slightly lower seroconversion rate. So we do have limited data on the vaccine efficacy in women living with HIV and their infants. Similar efficacy against influenza infection was reported amongst the HIV exposed and unexposed, but no difference observed in adverse events between HIV positive and negative pregnant women. So in terms of things like pain and the other complications that are or side effects that can occur with someone who receives a vaccine. So the timing of vaccinations in pregnancy. I had this slide previously where I used to have COVID in it, and I was sort of wondering what I should do with COVID-19 in terms of vaccination. So I went hunting on the National Department of Health website to see where can I go and get vaccinated, and it comes up as an error message, actually. So I got an error 404, and didn't matter how much hunting or the AI tried to help me, but I cannot find where you can still get vaccinated. And certainly everywhere that I ask, I just don't know of anywhere that's got COVID-19 vaccine. But as I said, it takes time for guidelines to change or to be updated to what the current practices are, or current availability is even. So the guidelines all still contain COVID-19 as something to be vaccinated for. And certainly on the CDC website, they're still talking about the 24-25 strain, that it should be given to vulnerable populations, and pregnant women generally do fall into that, as well as elderly, etc. But the availability of the vaccine is just, yeah, there is just no availability that I'm aware of. And my hospital didn't vaccinate even during the COVID pandemic. So we've never carried the vaccine ourselves, and it's not something we actively doing at the moment. So I think until there's another wave and the availability then, comes through, I think we can park the COVID-19 vaccine. With influenza, though, we're going to now vaccinate at any point during a pregnancy. Influenza vaccine really is more about mom. Yes, it's important that our baby does not get influenza, but we know that moms have a higher risk and morbidity and mortality with influenza. So hence the any gestation. Once you're into the season, we want to protect those mums from being ill. And we certainly have had a number of women with lower respiratory tract infections admitted over this last couple of months. So preferably early in the season, as soon as it becomes available, we should be administering it. The Tdap, so the optimal time according to the NGOH is between 26 and 36 weeks of gestation, but it can be given again from 20 weeks of pregnancy. And if we're then considering you might have a preterm baby at 27, 28 weeks, I would advocate then to vaccinate those mums as soon as they reach around 20, 21 weeks. And we repeat it in every pregnancy. The RSV, at the moment, the CDC, and I'll talk a little bit more about it just now, the guideline is 32 to 36 weeks, and that's from the CDC. And at the moment, it's once in a pregnancy. There's not a lot of data yet for the subsequent pregnancy, but that data is sort of in progress. And I suspect it'll probably be in every pregnancy as well. Oh, there we go. There's the error page when I was hunting for a vaccine site. Oops, the page could not be found. Okay, so sorry, let me just remove that thing. Right, so the Sentinel surveillance in South Africa, the respiratory pathogens report. So this is produced by the NICD regularly, and what we can see from them is that our influenza season started early this year on the 24th of March, or the week of the 24th of March, and it's earlier than usual. But the rate of increase was slower than usual, and morbidity, according to them, was still currently at a low level. So this surveillance, there are a number of surveillance sites, some in private, some in government, and from across the country, and they collect swabs and have a look at what strains are currently circulating. And this information also feeds in later to informing what the vaccines are going to be going to the Northern Hemisphere. So the Northern Hemisphere helps us figure out, and Southern Hemisphere helps with the Northern Hemisphere as well. RSV started on about the 10th of March, and it reached a higher threshold in the week of the 28th, but and had peaked the following week on the 5th. And already by the end of May, the activity has been dropping and is fluctuating between a low and moderate level. In the past 6 months, they've tested over 4,000 samples, and you can see the breakdown there. 11.7% cases of influenza, 16 of RSV, 2.8 of SARS-CoV-2, and 0.6 of Bordetella pertussis. We certainly get, because I've got the app for notifications. I get to see the notifications coming through to the hospital, and I must say it is actually quite regular that we are told that we've got another child who's been tested positive for pertussis. So just a little bit about tetanus. Within South Africa, you can see there the Tdap vaccine preventable cases. So this was between 2000 and 2023. There were 268 cases of pertussis, so you can see by far the bulk, and then diphtheria around 17, and neonatal tetanus 2 across that period, and this is what was being reported. So there's an image then of a baby suffering from tetanus. Officially, we've eliminated tetanus within South Africa back in 2002, and that definition works out as less than one baby being reported per 1,000 live births per district per year. So it doesn't mean that there are no cases, something like polio, where we have achieved eradication, thankfully. So tetanus, that is the definition we use. So that said, there were 2 cases then reported back in 2020 in Mpumalanga, 1 infant demised, and it's usually related to poor cord hygiene. But I think it's really important, again, when you're considering that life course vaccination, to remember to vaccinate people who have small injuries and things. I heard a sad story out of the Barra ICU a few years ago, where a guy was in a car accident. He had a very minor scratch, never received any prophylaxis or vaccine after his accident, and he later died of tetanus in Barra ICU. It takes time to develop. So please, the approach to vaccination, it really needs to consider everyone. So then pertussis. Here we want to protect our baby from whooping cough. I do recall having a really miserable night with my baby coughing. Actually, we of course were on holiday, as one does, and my baby started coughing, my youngest, and we then spent the night in East London in Beacon Bay Hospital with her on nebs. It really is a really frightening thing to see your child not being able to breathe properly. With antibiotic resistance, this is one of the reasons why we vaccinate, to try and reduce the risk of developing antibiotic resistance. Because if we're going to keep using all our antibiotics, eventually we're going to have none left. And with pertussis, our drug of choice with neonates is clarithromycin. And pregnant woman, it's erythromycin, but it's not widely available at the moment, so azithromycin is used. And worryingly, within the Asian region there, within China especially, we are seeing a lot of macrolide resistance. So most of over 50% of the isolates in China have come back as resistant. And if we lose azithromycin, we really are going to be in a bit of trouble with how we're going to be treating our pertussis. So again, the option of vaccination really is important. So there's the changing macrolide resistance of circulating Bordetella pertussis. And so their drug of choice actually is Bactrim. But it's going to swing in roundabouts. If we are going to abuse one drug, we're going to land up losing another. So we need to be very careful and try and protect the antibiotics that we have. So last year, Tdap was now started to be, we rolled it out within government. It had been available for a little while before in the private sector to give to patients. And so we really have had quite an active campaign in trying to raise the awareness of vaccination in pregnancy. So you can see there this was kindly supplied to me by Sanofi, and we can see the number of vials that were supplied to the NDOH, and those have pretty much, for that period of time, all been used, 1.8 million. So the number of deliveries in the country per year is roughly 1 million. And so obviously we've got slightly more vials than that that have been supplied. And we can see the increasing numbers towards the end of the year as more and more places received it. Obviously, a lot of them will use up had to use their tetanus toxoid that they already had procured first before implementing the Tdap. Then on to diphtheria. So the diphtheria has always interested me with Tdap because it sort of hitched a ride with Tdap. We focus a lot on the pertussis, the acellular pertussis that's with it. And obviously tetanus is something people have always known about, but the D kind of snuck in there. And certainly this year we've had quite a surge in diphtheria cases, especially in the Western Cape. So clinically it presents there with a sore throat, low-grade fever, and then that adherent membrane within the nose, pharynx, tonsils, and larynx, grayish white and firmly adherent, and enlarged glands in the neck. And then worryingly, if you get these toxin-mediated systemic signs with myocarditis, a polyneuropathy, and renal damage. So this is again, off the NICD, the situational report for diphtheria as of this last week. And you can see we've had a lot of activity. I had to talk earlier in the year, and I was comparing my two graphs. I think my first graph ended probably somewhere in the green there where the little blue bar is, the first time I had a look at it, and there's been a lot more cases since then. So each of them then has a public health response where someone's gone out, they've gone and swabbed everyone else in the area and vaccinated. But diphtheria is something that must not be discounted, and it's great that we've got the vaccine, but please be very careful in your practices and be aware that it is circulating at the moment. So back in 2015, or just after 2015, this was published, and they were looking at one of the lessons for diphtheria in the respiratory lessons that they learned from an outbreak. I think, if I'm not mistaken, was in Natal. And these are the things that affected it, power outages. And so there was an unreliable vaccine cold chain, that there was a limited capacity for vaccine surveillance. We had a less than 90% vaccine coverage. And these immigrant and refugee populations that were introduced, and there were unvaccinated individuals there, and then poor school or clinic attendance, and they're missing out on the routine and catch-up immunizations. And I think this is a common problem throughout all of these issues throughout South Africa, affecting our cold chains and things, and really affecting our ability to provide public health appropriately. So we also have an issue of poor maternal education. So does the mother know that she needs to give all these vaccines? So a lot of the education has to happen in the antenatal clinics. And certainly my antenatal clinic, the number of languages that are spoken is extreme. And so it does worry me that when the sort of broad education is being given to an entire population who's sitting there, 150 people, that possibly half of them don't understand the language that's being spoken. There's also then the lack of access to healthcare. So I explained the patients who are coming to me from Diepsloot, the fact that they have to spend 2 taxis, got to drive in to Randburg, another taxi from Randburg to Rahima. It gets very expensive, especially if there are multiple visits. So trying to align visits with other things like other appointments for GTT testing for diabetes and sonars, to really try and reduce the burden on patients of traveling around. Then financial difficulties and location promotes non-compliance, and that there's a stock of the diphtheria antitoxin is not being maintained, which is required for the treatment of people who are very ill with diphtheria, and then we're not giving adults, again, routine boosters every 10 years. Now that there's a Tdap rather than just having tetanus toxoid, certainly something like in your EDs, and if you're going to be offering it in your rooms and in like a GP practice, offering Tdap is such a great idea, because now you're going to get the benefit of all 3 different pathogens, and you're able to protect against all of them. Right, so the management of the diphtheria is azithromycin or penicillin, or you need that diphtheria antitoxin to neutralize the unbound toxin. And then there's the contact tracing and chemoprophylaxis, should be started prior to lab confirmation. You cannot sit around waiting for a lab if you're concerned, and there needs to be an early administration of the antitoxin and airway management. This is the NICD doctor on call number, so if you're concerned about your patient and you need advice, you can take down this number, and you can get some direct help. So especially those, well, when I first did the talk, it was the Western Cape, but it is definitely more widespread now. So please be aware of this. This is the app for notifiable medical conditions that you should have on your phone or on your practice computer, so that you can then notify the different illnesses as they come through. And then influenza, this little spiky fellow. So this is a global map of influenza vaccine policies. So you can see us in the green down there. We are a yes. So we do have a vaccine policy, again, published by the NICD, usually updated annually. And pregnant women, healthcare workers are on their list of vulnerable populations. So how did we do last year? Not great. Vaccine coverage was low at 5.5%, but this is also because we really just don't get in enough doses. So those of you who are working in areas where you're likely to be exposed to patients with influenza, you really should get your flu jab. The vaccine effectiveness, however, was good at 74%, and the mean onset was about the 3rd week of April and continued to week 25 of the year. So that was our flu season last year. The burden of disease annually, 3 to 5 million cases of severe illness, with a number of up to 650,000 deaths globally. In South Africa, 14% of inpatients have a lower respiratory tract infection, with 25% of them having an influenza-like illness, and they then have influenza. It is a severe non-fatal illness, 1,550 per 100,000 individuals, and deaths at 80 per 100,000 among individuals under a year. So it is a very severe disease. And then amongst our pregnant patients, we have 646 to 1,428 per 100,000 seasonal influenza deaths in women of childbearing age in South Africa. So a relative risk of 2.8 if you're pregnant versus non-pregnant women. But the problem here really is that 90% were HIV positive. While we have made some gains with HIV, that it has dropped down to about 27% in the antenatal surveillance, Rahima is a little bit different. Ours, a slightly different socioeconomic population around us, and we sit at about 19%, but that still means 1 in 5 women. So if I'm delivering 1,000 a month, 200 of them are HIV positive. The 10 leading underlying natural causes of death in South Africa between 2017 and 2019, and you can see there that influenza and pneumonia was in that top 10. I highlighted it over there. So birth outcomes after pertussis and the influenza diagnosed in pregnancy. So this was a retrospective population-based study. So they looked at almost 1.5 million singleton births, and there was pertussis in 925 women. Of 5.3% required hospitalization, influenza in 2,850, and there 38% required hospitalization. So influenza in pregnancy really is a very serious illness. So those patients with both pertussis and influenza, they tended to be young, they'd had a previous birth, and they were often overseas born. This was done, this is data from Australia, because you see there they're mentioning Aboriginal and Torres Strait Islander patients, often those with hypertension and diabetes, which is very prevalent in their population, are more likely to have influenza. So those with people who had either pertussis and influenza were more likely to have a preterm birth, a low birth weight, or a lower 5-minute APGAR score. Specifically with influenza, they're more likely to be SGA at some when they were born. And if the infection was 2 weeks prior to birth, that did increase their risk of preterm birth and lower 5-minute APGAR scores. So we really would prefer to prevent this sort of illness in our pregnant patients, and hence I would recommend that we try and move that pertussis, that Tdap should be given closer to 20 weeks, because certainly a woman's respiratory effort is going to be compromised in the second half of her pregnancy with a growing pregnancy, and so it's far better that she is protected against these illnesses. This is the influenza laboratory surveillance information from a site called FluNet, hosted by the World Health Organization. And in it, we can see there the huge spikes around July. This is from 2022 to 2024, and all the different influenza subtypes are characterized here. And again, this information is used to decide what kind of vaccines are going to be coming through. So with vaccine effectiveness in influenza, across with 19,450 hospitalizations. This was published in the CID. With respiratory illness in pregnant women across sites and seasons, 13% of PCR-confirmed influenza positive pregnant women were vaccinated, compared with 22% of the influenza-negative pregnant women. So 16% of women were vaccinated against influenza prior to hospitalization, so very, very low rates of vaccine coverage. And the 2010 and 2016 vaccines offered moderate protection. So I showed you earlier that our protection was around 74% for last year. So finally, to the sort of new vaccine on the block, this would be RSV. So I like to sometimes try and understand where a name came from. So pre-fusion F vaccine. So I went and had a look. So 2 major glycoproteins are on the surface of the RSV virion, and there's an attachment glycoprotein and the fusion glycoprotein, and these control the initial phases of infection. So what they've done is they've targeted that F glycoprotein. So G targets the ciliated cells of the airways, and F causes the virion membrane to fuse with the target cell membrane. And so we've targeted by neutralizing antibodies induced by infection. So antibodies that recognize the pre-fusion protein are much more effective in neutralizing RSV than antibodies to the post-fusion SF protein. So hence that vaccine is called the pre-fusion F vaccine, because we are going to that little glycoprotein. So this is the timeline for FDA development of the vaccine. We can see back in 2021, obviously there was loads of work before this on the phase 1 and phase 2 trials, but things really got exciting in September, where they started the phase 3 clinical trials in adults. In March of 2022, there was the breakthrough therapy designation. This is all by the FDA for the prevention of RSV in infants from birth up to 6 months of age by active immunization of pregnant women. Just before this were always the older adult group were generally just ahead of the pregnant group. These were the people that the groups that were being targeted. So firstly, older adults, secondly, pregnant women. So in November of 2022, then they got the data through for the phase 3 global maternal immunization trial. And then the biologics license came through, and then the advisory committee voted in support of approval in May of 2023. And in August of 2023, there was the approval. Basically, this then was in the States for active immunization of pregnant women at 32 to 36 weeks to protect infants. So pregnant women with RSV mostly are going to present with a cough, a headache, rhinorrhea, and a sore throat in descending order. Generally no fever, but it's not associated with an adverse pregnancy outcome postpartum. But those mothers who are affected, so RSV infection in a mother was associated with infection in basically half of their infants. 29.8% of mothers investigated within a week of their infants having RSV tested positive. So if we can protect and prevent the mum contracting RSV, we'll definitely also improve things for her infant. The RSV vaccine then is, its indication is active vaccination, and there are the 3 groups currently. So pregnant woman, 32 to 36 weeks for the prevention of lower respiratory tract infection, those who are older than 60, and then everyone else, the adults, who are at an increased risk for a lower respiratory tract infection caused by RSV. So that really does open it up to interpretation. Who's at risk of RSV? It does tend to circulate through most of the year. So our guidelines or our recommendations that have been given from NAGI, which is the national group who advises the health department, that for RSV vaccination should be recommended throughout the year because we do have circulating virus all the time. The warnings on the package insert are that there's an increased risk of Guillain-Barré up to 42 days post-vaccination. And then this one caused a lot of controversy, the increased risk of preterm birth. And I'll unpack it in a little bit in a moment. Adverse reactions, as in those things experienced by more than 10% of the patients, pain at the injection site, headache, muscle pain, and nausea, which are reasonably common for patients getting a vaccine. So this was the big article out of NEJM, and you can see we can be proud to be South African. There's Prof. Mahdi, the second author there, just after Kampman. A lot of this work was done at Baragwanath. We were one of the big sites in South Africa who dealt with this in the Matisse study. So it was a phase 3 double-blind study in 18 countries, 1-to-1 ratio, 24 to 36 weeks gestation. They gave the vaccine, and their bivalent RSV pre-fusion F protein based vaccine or a placebo. And there were 2 efficacy endpoints they looked at for medically attended lower respiratory tract infection, and then medically attended RSV-associated infection at 90, 120, 150, and 180 days after birth. And they did meet their first primary endpoint, that 81.8% vaccine efficacy within 90 days of birth. So we prevented a lot of illness when they compared those babies who received the placebo versus those who did not. And it was about 69.4 within 180 days of birth. So it was very encouraging data. Sorry. So then came this next article, which is why I say about the preterm birth. That preterm birth, unfortunately, a lot of the numbers for babies being born preterm actually came out of South Africa, and that was partly because the data was collected during the COVID pandemic, and we had an increased rate of some preterm births. So there was a lot of work done to see why did this preterm birth thing come up. So in the end, after having a look at the different data, they decided that there wasn't an increased risk of preterm birth, but the package insert as such is not yet changed. But our guidelines, which have been recommended to Department of Health, are that we are able to give the vaccine from 28 weeks gestation, not the 32 to 36, which is currently in the package insert. If we don't give it at 28 weeks, we are likely not to protect enough babies against RSV. So there was no definitive cause between vaccination and preterm birth identified. So I think it is important then when you are going to be counseling your patients to be aware that it was likely due to the issues of timing, really, in the middle of another pandemic to be running a massive trial. So with awareness and acceptability of vaccines, we really need to try and get our patients to accept vaccination. Within a government setting where we've got our big clinics running, it tends to work as sort of well-oiled machine. The patients come in, they go through to all the different rooms, and it's quite easy. We procuring large amounts of vaccine, and I actually, as a doctor, don't really have to think about it. By the time the patient gets to me in my room, there's a little sticker there already saying that the patient's received Tdap. What is trickier is when you're sitting in your individual practice, having to make sure that you have incorporated your vaccination discussion and education into your routine practice. So it really is important that you have a sort of a plan for yourself. If you're not using the government-provided maternity care guideline, not guideline, sorry, case record, that you develop for yourself a system of saying, okay, well, we've reached this gestation, probably given your patient some pre-reading. It's a good idea, so that when you get to having the discussion, it's time is money, I know that, that you can keep your discussion reasonably short and answer any of their queries. And then depending on where you're working, are you working in an area where you've got a pharmacy outside your door? Are you a provider who actually has vaccinations in your own clinic, that you're able to give them that script and get the patient to go get her vaccine? So one of the things that we look at then, that there's low awareness and belief that vaccination was unnecessary due to perceptions of a low risk of infection, illness, and death. Patients don't see it happening to themselves. And, even when I'm giving these numbers out here, per 100,000, it's quite abstract for a patient to understand. And sometimes, I suppose, even doctors, if they're within their smaller practice, they're not seeing it. You might get one case every so often. And so that perception of risk is quite low sometimes. Patients have high information needs, and these needs are best met by a familiar healthcare professional. It's been shown over and over again that patients are more likely to accept a vaccine and go and have it done if their healthcare professional tells them to do it and advocates for it. If you do not do it, it's unlikely that the patient will go and procure it herself. You need to address their concerns and communicate risk whilst taking into account the factors regarding health individualism, and then also gender roles. Our antenatal clinics, again, are, especially unfortunately in government, often quite exclusionary. The dads are not part of the party. And so patients are there on their own. They don't have a support person with them. And so it's quite important also to consider, sometimes people want the permission of their husband, or to at least discuss it with their husband. And these sorts of dynamics need to be taken into account. We need to deal with the misconceptions that vaccines cause illness and disease. I know my mother's actually one of these. If I tell her about the flu vaccine, she swears blind it makes her sick. But this year she decided no, because she was so sick, she actually went and got her flu vaccine, which I was quite pleased about. People have a fear of needles. And then again, I said there no provider recommendation. Sorry, there's a duplication there. So the healthcare providers, when it comes to vaccination, really need to be out there with their pom-poms. You need to be advocating for your patients, to deal with the lack of knowledge of your own. So this is why you take part in webinars like this, to up your own knowledge and education. And do remember that if you've got a whole bunch of people in your practice, you've got the receptionist at the front who needs to be able to direct the patient back to you, to wherever the correct sources are if the patient stops and asks. If you've got nurses working with you, that everyone is on the same page and has received enough knowledge and education about it so that they're able to explain the point of the vaccines and what's going to be protected. Some doctors have also sometimes considered that vaccination is outside their remit. So not part of their practice, not my job. It's everyone's job, and generally promoting herd immunity and sort of general public health processes is really for everyone to consider. And like I said, I understand that people have sometimes got quite a short amount of time to talk to patients. So do try and make sure that you've got information available, or you can direct patients to reasonable sources of information so that they're able to at least go read it and then ask the question the next time. The issue of having time, as I've said, it is all about your time management and how you put together your practice and how you decide to educate your patients. It's also not possible to tell your patients in a pregnancy about everything on the first visit. There's just too much. And that information overload means also the patient's not going to take anything in. And so, again, I would try and work out at each visit, assuming you have, say, 8 visits across a pregnancy, what are you going to be discussing? And maybe also prep a patient. Next time we'll chat about how we're going to manage your delivery. So the patient knows and comes with her questions and is able to then engage with you. Also gain that perceived low risk of disease in your patients, perceived lack of clinical trial data with vaccines in pregnant women, but there is a lot of data, and then other administrative difficulties. So making sure as well that the pharmacy nearby you, actually has the vaccine available, and that there's someone then to administer the vaccine. So all of those sorts of things do need to be looked at. Right, and there we go. So that would be a picture actually taken about 2 weeks ago down in Sinsa in the Eastern Cape, a beautiful part of the world that I really love. So thank you very much. I hope I didn't speak too fast.
No, you did not. Thank you, Dr. Wise. It was actually quite informative and perfect. And thank you so much for covering as much ground as you could in this period of time. I know that a number of questions will follow, and one of those will be if colleagues needed more information, or they needed guidance or a place to obtain information from, are they able to contact you? And if so, where would they be able to do that?
My email is on the Wits website, so they'll find me on amy.wise, so that's fine. And then otherwise, I really do think both the Knowledge Hub, which is the Department of Health's website, which has got really fantastic PowerPoint presentations and things that are available. Download the 2024 Department of Health Maternity Care Guideline, the integrated guideline. It's a really fantastic resource. And then also NICD. I think going to NICD, they've got really excellent, what's the word I want? Summaries and everything on the different illnesses. And as well as they had that number up at some point, the NICD doctor, especially if you've got someone who comes in who's particularly ill and you're worried, for example, something like a diphtheria or an mpox or something. I was listening this morning, they're talking about doing targeted vaccine campaigns for mpox. So these things are not not around. They are. So please do have those sorts of numbers and have the notifying app on your phone so that you can notify appropriately.
And it's exactly what you refer to right now, is that if colleagues wanted to remain updated, because this is your field and it's something that you do on a daily basis, but you said we need to incorporate this into our practices. But for general updates, are you some of the sites or information sources that you could potentially or elaborate on, so people could just be aware of any of the latest changes or dynamics in the market?
So NICD updates annually, like their influenza stuff, and then there's the respiratory surveillance report comes through every week. So if you go onto their website, so like that graph that I showed there, the diphtheria one, it's updated weekly. So if you're interested in knowing what's happening sort of in the infectious space, then that's the place place to have a look.
Yeah.
I see there was a question somewhere along the top there, something about COVID, something about COVID.
Mhm.
Um, Asking, was there any significant decrease in infective incidents? There was definitely a dip in the RSV, as far as I know, and the respiratory illnesses and things, just because of everyone, wearing masks and but the pattern has returned now to sort of normal. Yeah. So there was definitely an improvement, but I don't know that I could live with a mask forever. So.
There was
But
another question.
hand washing is important. And I think if you're ill, certainly I think it's become common practice now that if you are ill and you're going out, that you both for yourself and everyone else, that you wear a mask and that you don't unnecessarily expose people to illnesses. But this is also then, yes, you can prevent like me coughing on you, but go and get your vaccine.
So there are many people that are complimenting and thank you for the presentation, Dr. Wise. Another one of the questions is, were there any illnesses, example, emboli, that resulted following the COVID vaccine, for instance?
There were in the post-marketing, implementation phase, an increased risk. I think we've all heard a bit about long COVID. We've heard about the myocarditis, and I think embolus on its own was just found with COVID. Certainly, we experienced it that patients definitely more hypercoagulable, and we had patients on our side who sadly demised from it. And I think it's going to probably take a few, well, not too many more years, but for everyone to gather all that data to really see how much was due to COVID, how much was due to a lack of access to healthcare, that people were unable to get their normal healthcare, and therefore diagnoses were delayed for other unrelated things, and also then trying to work out that timeline. Was it truly the vaccine, and which was related to whatever incident happened? So there is quite a lot of data already out there, but I think at the moment, I do suspect that that's also probably why people are a little bit wary, because they're waiting to see a little bit more information that comes out. And like I say, I really did go and have a look to see, can we still get the vaccine? And since it's still on the CDC website, and then those who are following politics would have heard that, what's his name, Kennedy had taken it off and then taken it on. There's been a lot of movement within the states, and it is something we're sort of waiting to see what happens, because CDC really does direct, and the NIH really do direct a lot of our health policies, or at least help provide some background for it. So it's important that institutions like that are working and functional, so that we're all able to better protect ourselves. So yeah, sorry, long roundabout answer, but yes, there's definitely some associations, but it's really important to consider how many people were saved because of the COVID vaccine.
Mm. Yeah, thank you. Thanks, Dr. Wise. I think it's Professor Adam is asking, should mothers be vaccinated pre-pregnancy for RSV? And what about Group B strep?
So Group B strep is also, I think, in phase 3 trials, if I'm not mistaken. And so they are working hard. I think Group B strep is a very important cause of neonatal death, and as well as stillbirth. But with the before pregnancy, Prof, I'm not sure whether or not that's being considered. They are saying that there's some sort of, they're expecting us to have to vaccinate in each pregnancy. And the whole trick, I suppose, would be how sure you are going to be about falling pregnant. And then is it going to mean that you're going to need another vaccine during that pregnancy if there's a delay to falling pregnant? So I think we'll have to ask Prof. Mardi.
Yeah, they were an interesting question. Yeah, thank you for the presentation. The question is, should we not be promoting vaccine administration training of allied healthcare professionals, especially pharmacy, so vaccines can be administered at the point of purchase?
I'm not actually sure. Maybe one of you can tell me about, is a pharmacist allowed to administer? And I suppose that would require a change within the HPCSA if they're currently not allowed to actually administer something like that. So certainly nurses and things. This is why I would like to see certainly anywhere that there's a collection, or so if you've got a hospital group, it's not always possible for your one individual gynae to be able to administer all vaccines and within their room. So I would hope that if there's a pharmacy attached to a private hospital, that there's maybe a small clinic, a bit like a Dis-Chem kind of setup, where there's a nurse within the Dis-Chem setup, and you can go and get your vaccines and your pap smear and your sort of really sort of primary healthcare sort of thing. This is not something that really should have to go to a secondary or tertiary level of care. It shouldn't only be a specialist who is prescribing this stuff, because that really just then actually adds a barrier to care. I think it would be far better that people work these sort of programs, private and government, that there is a clear pathway, so that if you've got a hospital and a Clinix group, that you have thought about as a hospital, where are we going to put a primary healthcare type setting, that all the doctors who work within our area are able to send people there, so that you try and remove the barriers and the administration around it, that it becomes an easy thing for someone to say, right, you're at your 20-week visit, you can go down to the clinic, they will assist you with doing, you're getting your vaccine and everything. So I think that kind of it requires some cooperation. Sometimes people kind of run their practices in little islands.
Yeah, there was a question from Daniel Matthew Thomas. She's actually a clinical pharmacist in the Clinix Health Group. Daniel, are you looking to have that question expanded upon, or are you're comfortable with the answer? Okay, so
I see something about Knowledge Hub is at lunchtime, and patient are needing a recording available. I'm not sure who runs the Knowledge Hub thing. I mean, I know the slides are available. I'm not sure about the recordings themselves. I myself struggle to sit and listen to something in the middle of the day. That's why these sorts of times are that much better. I'm not sure who actually runs them, to try to get the recordings available. And then something about polio drops. That again is not something I don't know about the procurement issues with polio drops.
Okay, we make our recordings available on our YouTube page, on the Clinix YouTube page.
Perfect. Someone asking about the RSV being an annual vaccine. So the NAGI have said that they suspect it would probably be every pregnancy, but we're waiting, I think, for a little bit more data to look at what your fall off is of your IgG. So maybe if you have your pregnancies very close together, it's going to be enough. But I think that's going to require a little bit more research to see how long does it last for, and does it cover the next pregnancy sufficiently. And so I think we'll get that answer soon. But they've already suggested they think it'll be every pregnancy.
I know, Dr. White, you said you're going to follow through on the questions yourself, but just in case you're missing a few, there's a question about rubella and hepatitis vaccines given in pregnancy.
So Hep B is only if if absolutely necessary. It's sort of a risk-benefit thing. There is also a hepatitis B working group that's busy looking at the vaccines and trying to get all the different guidelines to sort of speak to each other, because hepatitis B comes up in both pregnancy guidelines. It comes up in there's a very big Department of Health guideline that's come through, and so they're just trying to get them all aligned so that they all speak to each other. At the moment, it's not a routine vaccine in pregnancy, but what we are doing is a Hep B surface antigen routinely, and that should be routine in every pregnant patient, looking to see are they carrying and whether or not they need then prophylaxis to protect baby. So everyone who's dealing with a pregnant patient should see that they've done a Hep B surface antigen. If it's positive, the baby should be vaccinated at birth, and rather than waiting for the routine vaccine that's provided with the EPI. And rubella we don't do in pregnancy. If you have received it, it's not a problem. If you were early in your pregnancy, we don't do anything. We don't, terminate your pregnancy or anything, but we would prefer patients to have received their rubella vaccines as part of, and it is back again, prior to ever falling pregnant.
We are unmuting one of the clinical pharmacists that would like to have a question posed to you, Dr.
Sure.
Wise. And yeah, so this is Dania again. Dr. Adams said, Professor Adams says we are vaccinating babies at birth in mothers negative in the Northwest.
Yeah, I think so. I know that that's one of the options. And so I think this is why the vaccine, they've put together a working group so that we can try and align all the guidelines, because that is one of the options to try and get it done earlier rather than waiting for the 6 weeks. Then the question is, do you still do all the Hep B surface antigens on everyone, which I think maybe is a good idea, because you then do pick up moms who are at risk of later developing hepatitis illness, and you can try and reduce also then that transmission by getting the patients onto treatment with Truvada. But yeah, that is one of the options. But I think as a program across the country, they've got to come up with a single set of guidelines. So I think we've got another meeting in a couple of months.
Okay. I know I keep, whenever time I mention Prof. Adam, you smile.
Yes. Because she always has the toughest questions. Yeah. those people in exams with Prof. Adams coming along. I don't know, she got her voice on somewhere. She
I know you can take it to task tomorrow. I know that
no, well, she snuck off to the Northwest, so it's a little bit harder.
Yeah, you're gonna it's Friday, you can take a drive. I know that Prof. Adam has also joined us, obviously, on this call, and Prof. Adam would like to do the vote of thanks. She kindly recommended you, so you come highly, praised. So thank you so much again, Dr. Wise, for coming. Prof. Adams, if you could please come to the fore.
Up there.
Can you hear me?
Yes, thank you so much, Prof.
Okay, great. So, thank you so much, Dr. Wise, for coming to do this talk. I think it's such an important talk. I think particularly highlighting that immunization is not just for mothers, but for neonatal health, because mothers listen when it's for their babies. And of course, I think neonatal tetanus has been such a great example of what can be achieved through sustained public health efforts. I just want to also say, the influenza vaccine, if you have a patient who's got influenza, you've got such a small window of opportunity in order to give the Tamiflu in pregnancy, that the vaccine is just so important. So, I really appreciate that I certainly where we work, as you say, all of these things happen in the background. But in terms of general practitioners and obstetrician gynecologists in private who look after pregnant patients, they really need to think about influenza, because you have to only lose one mother from influenza to be convinced. And then I must also thank you for your dedication and continued advocacy for keeping Rahima Musa going. So thank you, Dr. Wise.
Still standing. Yes.
And a special thank you to Clinix for your support in making this important event possible. I think there were, at one time, more than 350 doctors who had logged on, health workers who had logged on at any particular time. And then thank you to the audience for your presence, your engagement, and for the questions, because that really helps us. And then thank you for Tolakele in the background for always hosting and keeping the technology going. Thank you.
Thank you to Prof. Adam. Not only now, we sit on different platforms, and you're always very helpful, and even on a primary healthcare level, helping with the nursing education. Many times people think that professors are too busy in various capacities. But thank you so much for the help that you're also providing, the nursing, clinical, and the executive teams within Clinix Health Group. So on behalf of the Clinix Health Group, I just want to thank the management team as well. And you mentioned some of the technical aspects behind the scenes, which are quite intensive. I just want to say thank you to the marketing team, Tolegele, for that. And thank you to the Clinix Health Group for making sure that these are available at no cost to yourselves. And we hope that you will continue to join us. And Dr. Wise, feel more than welcome to come back again when you said you are doing an extensive amount of research. So when any other developments come to the fore, please feel free to join us again and share those valuable insights with us. So I wish to thank everybody and have a blessed evening. Thank you.